Thank you very much again for the invitation, for the kind invitation. It's a really great pleasure and a great day here in Krasnoярsk. And let me introduce about this topic, about novel respiratory devices to prevent aspiration pneumonia. So, when we design devices for prevention of aspiration, as any device that we design, I think the most important thing to consider is the questions we are going to answer. And I'm saying that because we have lots of devices, as you can hear also in our stand on the other side. So we have lots of devices in the ICU, and we don't need more just because they are fashionable, but they need really to answer to a clinical problem. So this is really banal, very simple, but actually it's extremely important because otherwise we multiply devices, gadgets in the ICU, but really need to address a clinical issue. With this in mind, regarding aspiration, I think about the four possible mechanisms by which aspiration may occur in patients that are in the ICU. When we introduce an endotracheal tube, we disrupt the normal homeostasis of the airways, while we, of course, rescue patients from any conditions in which they were either emergent conditions or in the operating room. We need to keep in mind what is the trade-off of inserting an endotracheal tube. And I think about these four issues when we intubate a patient. First is gravity dependent, which means that by gravitational forces, secretions, of course, they go from at higher level to lower levels. And so if we have a patient in a semi-recumbent position, so patient's bedside is up, so then of course there will be secretions that drain towards the airways, and then subglottic pulling. And there are two really areas that I'm interested in, is the outside of the endotracheal tube, which means the endotracheal tube cuff sealing against the tracheal mucosa, and the inside of the endotracheal tube, the lumen of the endotracheal tube. So for the first point is the gravitational. This is a video of a ship that was mechanically ventilated. This is the trachea, this is the neck actually of the ship, and this is the endotracheal tube tip on the upper left corner. And what you see here, it's a nitinol, the titinol spheres that they come all the way up to close to the endotracheal tube tip, and then they go down towards the lungs. And it is just by clearance of the mucociliary clearance of secretions that come all the way up, but they cannot, of course, they cannot exhale, they cannot get out of the airways just because of the presence of the endotracheal tube. So we investigate whether also positioning can help patients in terms of clearing secretions. This was used a long time ago, like 100 years ago, for cystic fibrosis patients, especially in patients in a pediatric population. And really the position is the lateral decubitus position, which is like a prevention in patients that are not intubated in terms of clearing secretions. So methods that can help also clearing secretions without aspiration. This was a study we conducted it's a feasibility and safety study, and we showed that there was a decrease in aspiration by measuring amylase and pepsin, which is just the markers for aspirations in patients that were on the lateral position in the ICU. And this was in a pediatric patients, this group from a children's hospital at George Washington University in DC area, in Washington DC area. And what they did was newborn patients intubated. They kept it either on the upright position, on the lateral position, and they showed a decrease in infections in terms of pneumonia. A large trial, prospective randomized trial, is ongoing. It's now is actually completed, and the results should be shortly out. So I'm looking forward to see the results of this gravity VAP trial on positioning patients on lateral positions versus semi-recumbent position, because I believe that gravity plays a big role in the aspiration issues. But now let's go and move towards possible devices that actually help to decrease aspiration. So this is Pseudomonas aeruginosa with a green fluorescent protein that grows on a substrate of polyvinyl chloride. In 8 hours, as you can see, the substrate is completely covered by Pseudomonas aeruginosa. This is just the substrate of an endotracheal tube, like our normal endotracheal tubes. So there is really no way to prevent. Within 8 hours already the internal lumen of the PVC of the endotracheal tube is already coated by bacteria. And these are just some scanning electron microscopy of patients' endotracheal tube when they're just extubated patients. So you can see that there are lots of diplococci that are growing from the lumen, internal lumen of the endotracheal tube. And the reason is that there is no really way to clean, and first there is no autoimmune defense on the internal lumen of the endotracheal tube. And you can imagine that by breathing and by mechanical ventilation, there is a kind of a flow and aerosolization of these bacteria through the respiratory cycle. So these are just the standard endotracheal tube. I just took some pictures of a normal standard endotracheal tube when the patients are extubated, which is pretty gross, as you have all experience with. But the reality is that there is no really way to clean these secretions from the endotracheal tube. This is a video from one of patients that we did a reconstruction from a CT. If maybe starts, but basically what it is, it's a, I don't know if it works or not, or whatever, but basically what we did was a rebuilding with a CT imaging 3D of the lumen of the endotracheal tube. And what you see is basically that is all the Pseudomonas aeruginosa that is building up inside the endotracheal tube. It's okay, it doesn't work. And this was a micro CT reconstruction of the tubes of patients that were extubated, and what we found was that about 8% of the volume is lost in average, and of course going from the oral part of the endotracheal tube in yellow to the red part, which is really the tip, so the most distal part of the endotracheal tube, volume is lost, and the bacteria may grow more closer to the tip of the endotracheal tube and so dislodged to the lower distal airways. We did also studies for resistance, and of course the higher the volume loss is, the more resistance to airflow there is. So this is one at the level of like a 10%, as you can see here, the luminal air volume reduction is about 10%. There is not such an increase in pressure drop, but clearly with the higher increase in airways loss, there is a higher resistance pressure drops, and so resistant to airflow. In patients that were intubated and they had to go through a CT, high resolution CT scan of the chest, we tried to reconstruct and we look for a biofilm within the endotracheal tube. And what we found was the same, that the cross-sectional area of the endotracheal tube are lost. About 24% are obstructed in the maximal cross-section reduction area. So in order to decrease bacterial colonies, and what we did was to use a really of a combination between antiseptics and also bacteriostatic agents to coat the internal lumen of the endotracheal tube. And the idea was not to eliminate bacteria, but just to reduce the colonies. Because as we heard before, there is not really a part of the human body that is sterile. So like the lungs of healthy individuals are colonized by bacteria, and which is commensal bacteria. But what the idea was to reduce especially nosocomial bacteria that may be the source of infection for lower airways. So what we used was a combination between silver, sulfadizine, and chlorhexidine with different agents, with either carbon or using other, can be used also even platinum. And the idea was, and then also the rose bengal on the right side, you can see rose bengal for UV light. What it does is a combination between different properties, either to use a light source, just using UV light within the endotracheal tube, or to use instead antiseptics, as I said, or iontophoretic properties of the silver, which means that there is a current, very slow current of ions, not electrons, but ions of silver ions that basically destroys the wall of the cells, of the bacteria. We were very happy because the first report that we did was in cardiac anesthesia patients, and we randomized patients whether to receive some of this endotracheal tube or not, or just standard endotracheal tube. We were very happy because what we found was that the inner part of the endotracheal tube was, there were no bacteria, but these patients were cardiac surgical patients, so they were very short, limited period of intubation, as you can understand. When a study was repeated, and you can see actually the lumen of the endotracheal tube, on the left it's a new endotracheal tube, it's a cross-section. On the right side there is instead a very thick mucus deposition on the endotracheal tube. This is instead the very thin silver sulfadizine coating on the internal lumen before use and after use. So there is not really colonies and deposition of material on top of the tube. And when we did the confocal laser microscopy, this is basically it's a live dead staining. What you see on the left is that there are in green live bacteria multiplying, and in red on the right, on the silver sulfadizine coatings, there were no bacteria multiplying. So we were very happy about, but the limitation of the study was that it was a very short period of intubation time. When this study came out, there was a randomized trial in the US on the use of a silver-coated endotracheal tube in the intensive care unit. What they showed was that there was a reduction of ventilator-associated pneumonia in patients using this coated endotracheal tube. However, was not really a reduction. As you can see from the shape of the curve, it was just a delay. Because in the thick black curve, what you see is that there is just a delay of ventilator-associated pneumonia events over time, but overall, if you go by days, eventually there will be similar rates of infections. And that is explained by the fact that the silver, like any other coatings that are now available on the market, what it does is preventing a short period of time from bacteria to adhere to the surface. But differently from central venous catheters, that there is a blood flow and autoimmune response, white cells and antibiotics circulating, in the internal lumen of the endotracheal tube there is no autoimmune defense, and there are no antibacterial defense, antibiotics. So, and the other issue that we learned was that reality is that the biofilm removal that we use, that is just suctioning, is really not effective, because it never really is able to retrieve and clear secretions from the endotracheal tube. So Kolobov, that is an investigator from the National Institutes of Health, that is actually the inventor of the first that built the extracorporeal membrane oxygenator as we use it now, built also this device that used to clear secretion from the endotracheal tube, from inside out. And again, we tested together with him in a very small trial just to see the effects of this device. And again, we were very happy to show that there was no bacterial growth in the internal of the endotracheal tube, and it appeared very nice and clean. But then, can you move on? Next slide. Okay. Then when we repeated the study in a larger population with this device that now is commercially available, we really weren't able to show benefits in terms of we showed benefits here in red. There is really, again, the percentage of luminal occlusion in a standard group that were not using the device versus the blue, that there was a decrease, but really not so efficient as we hoped. And in terms of colonization of the endotracheal tube in these prolonged ventilated patients, there was no difference. So there were the same bacteria that were colonizing a standard endotracheal tube with the normal technique of suctioning was the same as in the cleaning endotracheal tube. And let me just move on. And so there was really no difference between bacterial colonization. And in conclusion, for the first part, that is really dealing with the internal lumen of the endotracheal tube, I think that what we learn is that the major issue for preventing aspiration is really just a gravity issue that needs to be. When the positioning is not feasible for ICU patients, then some devices can be used, but always knowing the limitations that these devices have, which means really that the mucus shaver, that is this cleaning device, and antibacterial coating can prevent or reduce bacterial colonization, but do not avoid it. What about the endotracheal tube cuffs? The endotracheal tube cuffs, as you see on the market, there is a lot. There is a shape different and also material difference. There is now in polyurethane cuffs and polyvinyl chloride cuffs. Most of these these materials, and also shape different. But when we investigate and we reported this data in laboratory studies, we didn't see any difference in terms of decrease in aspiration through these endotracheal tube cuffs. All cuffs that we use in the ICU, there is always aspiration through the endotracheal tube cuff. And the reason is that when we move from high pressure low volume cuffs that were used in the 1970s and before to high volume, low pressure cuffs that we use now. What you need to do is, in order to produce them, you need to fabricate a cuff that is larger than the diameter of the trachea of the patients. Which means that every time that you inflate the cuff, the cuff is going to be always larger and will make always some micro folds around the cuff, because the cuff is larger than the diameter of the trachea. And these microfolds allows always drainage of secretions around the cuff itself. In animal studies and in laboratories, we show that the critical elements for aspirations, the preventing aspirations or the reducing aspiration, are really some that are from the ventilator strategies using PEEP and PIC inspiratory. A very simple thing that probably that I would suggest all anesthesiologists is to use just standard gel lubrication before using an endotracheal tube, because this, just the gel lubrication, helps just to prevent leakage around the cuff itself. The only problem with that is that they last only for a few hours. So if a patient needs to be ventilated for long days, then it doesn't help. Only 4 cuffs at this time are really that are available. That are actually 3 of those cuffs are not commercially available, but only these 4 cuffs showed absence of leakages around the cuff. These are the only 4 that really exist. And the first one is this is latex, that of course has the obvious reason, the drawback in terms of using it at the bedside, which is the material, the latex. So there are patients that have latex allergy, but it's a nice design because it's a double cuff. There is an inner cuff that basically what it does, by inflation, stretch the outsider cuff that makes clear contact with the tracheal wall, allowing basically stretching and adherence, complete adherence to the tracheal wall. The second cuff is a lycra. Lycra is a material, it's a really polyurethane, but it's very thin, and what it does is that it's about 200 times more elastic than the polyurethane. And so what it does is that by inflation, it can actually apply to the tracheal wall, and it allows basically maintenance of pressure and therefore no formation of folds around the cuff. And this is the only one actually that is commercially available. It's a British company that produces it, and what it does is that is the one on top, on the right, which is called Pneumox. What it does is preventing leakages, because it's a polyurethane cuff, but it's high resistance, which means that in order to inflate the cuff, you need to have a very high pressure inside the cuff, but because it's latex, the transmitted pressure from the inside out is very low. It means like when you blow up a balloon, you need lots of pressure at the beginning, but the transmitted pressure outside is very low. The drawback of this cuff is that you need to know, or you need to approximate the size of the endotracheal, the size of the trachea of the patient to the endotracheal tube. And this is, I think, it's a shift in a concept to try to use absence of cuffs. This is also another design from Kolobov, from the ECMO inventor, which is, I think, is a very nice idea, because what it is a polyurethane membranes. There is no cuff, and the membranes, they just adhere to the wall because of the viscoelastic properties, because of the secretions and the saliva, to the wall of the trachea, and doesn't allow secretions, and it doesn't allow always airway leaks. However, no companies produces, just the idea, the concept, and they tested this material in animals. And this is the picture of the tube. In conclusion, I think that the problem of having, for now, we don't have a really single device that intervention that is effective on preventing ventilator-associated pneumonia and biofilm formation in the endotracheal tube. The only thing that has been shown was a decrease or a delay in ventilator-associated pneumonia, but there is not an avoidance. Mechanical biofilm removal of antimicrobial surfaces seems promising in reducing the rate of endotracheal tube pathogen colonization, but really, until now, there is not really proof for patient population targets or use it in the ICU. Endotracheal tube care technology bundles, which means using multiple technologies at the same time, should be investigated. Nobody really tried to put together some of these promising devices that may prevent late onset pneumonia occurrence. With this, I just wanted to thank all the team, respiratory therapist team at the Massachusetts General Hospital that helped me with these studies, and my first mentor, which is the oldest here in the picture, which is Dr. Kolobo from NIA, from the National Institutes of Health. Thank you.